Hello, this is Amanda Jovog. I'm the rankings team leader, and I want to welcome you to the 2017 County Health Rankings Introductory Webinar. I'm excited to share the new data, tools, and resources that will be available to you on the March 29th release of the 2017 County Health Rankings. I'm joined here today by my colleague, Kate Conkle, who will be fielding questions and chatting out links throughout the webinar. Kate, do you want to say hi?
Yep, hey everybody, it's good to be here. Thanks for coming.
Okay, so let's get started. So first we want to start by acknowledging that the County Health Rankings and Roadmaps program is the result of the contributions of many partners, including the Robert Wood Johnson Foundation, our colleagues here at the University of Wisconsin Population Health Institute, and the various partners who help us compile the rankings data and get the message out about the rankings and roadmaps. So here's our outline for today's talk. First, we'll take a quick look at the background thinking behind the County Health Rankings and Roadmaps program. Next, we'll look at what features are available in this year's measures and any data changes. Next, we'll look at some new additional measures. And finally, we'll take a look at what's new on the 2017 website. This year, you're going to notice an increased emphasis on data tools provided with the County Health Rankings and Roadmaps release. Once we're all done with that, we'll do a quick wrap-up and hopefully leave plenty of time for questions at the end of the webinar. Please feel free to use the chat feature in the GoToMeeting interface to send us questions throughout the webinar. Staff will be fielding them throughout, and I'll be checking in for questions periodically throughout the webinar. I'd like to note that since this webinar is pretty packed with material and will be focusing quite heavily on what's new for 2017, we'll only be providing the most cursory introduction to the County Health Rankings and Roadmaps program as a whole. If you're relatively new to the program, I'd suggest taking a look at one of the 101 webinars that we offer quarterly. Kate's going to chat out a link to one that was done in January, or you can sign up for the April 11th 101 introduction and website tour. So first, I'd like to start with a quick reminder of why we produce the County Health Rankings in the first place. Let's start with this guiding question. How can the County Health Rankings and Roadmaps help you build a culture of health in your community? The Robert Wood Johnson Foundation laid out a powerful vision for building a culture of health in every community in the country. That vision includes the belief that all individuals and families should have the means and the opportunity to make choices that lead to healthy lifestyles regardless of where they live. Not long ago, America viewed health as something that happened in the doctor's office, isolated from daily life. But today we know better, and research gives us a better understanding of how interconnected health is with income, education, housing, and a myriad of other factors. Oops, sorry, one click too many. So there's a tremendous need to shift from the old lens of working in silos, since we're finding that only a cross-sector approach can fully address these intertwined and complex issues. Each one of us is a piece of the puzzle of building a culture of health. The hope and vision of a culture of health has to be shared, and the circle of engagement needs to extend to the whole community. The truth is, everyone has a stake in the health of the community, from families to schools to businesses. In the same way, the County Health Rankings and Roadmaps program is made up of many components that work together with a common purpose, to build a culture of health county by county. So first, just a little reminder again, I'm going to say this date several times throughout the webinar, but our rankings release date this year is March 29th of 2017. So this slide shows the thinking behind the rankings, our theory of change about how rankings can be a catalyst for action that improves the health of everyone in a community. Starting on the left, we take population-based data that's collected by others, and we utilize this data to create an easy-to-use snapshot that compares counties within states and is released every spring. But we produce rankings for a reason, because they get the attention of media and can be used to start and broaden conversations about health in communities. Those conversations can then lead to broad community engagement and multi-sector partnerships that can in turn select and implement evidence-informed strategies to address community priorities and finally, in the long run, improve health outcomes. So essentially, the county health rankings aren't about numbers. They're about a call to action. We also know that while simple in theory, putting this model into practice is challenging. So we provide tools to assist communities in each area. And we're going to talk more about one of these, the rankings. So the rankings model that you see here is one of the most important images we'll share with you today because it shows what we use to determine the county health rankings and what influences health in a community. This model shows the relationship between policy, health factors, and health outcomes. The rankings make it clear that good health includes many factors beyond medical care, including housing, education, jobs, access to healthy food, and more. It shows us that all these factors impact how well and how long we live. Starting from the bottom, we know from research that effective local, state, and federal policies and programs can improve a variety of factors that in turn shape the health of communities. Many health factors in the blue boxes shape our community's health outcomes. We specifically look at health behaviors, clinical care, social and economic factors, and the physical environment. We measure two types of health outcomes in the green boxes to show how healthy each county is, length of life and quality of life. So let's try to translate this into a real-life example. Expanding early childhood education improves academic achievement. Higher levels of education can lead to higher levels of income, which can make it easier to access healthy foods, clinical care, quality housing, which in turn influence health outcomes. So you can see the interplay between the multiple factors that shape health outcomes. Now we're going to review the ranked measures available in 2017 and discuss some changes in the way our measures are calculated. For those of you out there who are County Health Rankings veterans, a lot of this section is going to be a review. However, if this is your first time engaging in the County Health Rankings release, there'll be a lot of new information. First, I'm going to talk a little bit about how we choose measures to include in the County Health Rankings. So how do we select measures to include in the rankings? It's an important discussion to understand why some measures we have are ranked, some are additional, and why we don't include some measures in our data at all. Our criteria fall into two categories: County Health Rankings and Roadmaps program goals and technical feasibility. First, let's talk about how we select measures to support our goal to support communities' efforts to improve health. All measures should reflect important aspects of population health that can be improved. They need to be modifiable. The rankings are about data and communication, so it's important that each measure and its association to health can be effectively communicated to the media, communities, and other key audiences. We believe that fewer measures are better than more. We believe that action is more likely if people aren't overwhelmed with too much data. We try to use our measures to speak to emerging health issues of importance that will bring current and new stakeholders to the table. We replace measures if we find ones that are more closely aligned with or provide better estimates of the underlying construct or idea we're trying to measure. We try to keep as aligned with other metric initiatives such as America's Health Rankings as is possible. And we look for measures that will advance efforts to address health equity. So we prefer if our measures can be explored for smaller geographic areas or for specific population subgroups within counties. In addition to those, we have some more technical criteria. Since these are the county health rankings, we use data that are available at the county level. We get a lot of questions about why we don't include one measure or another, and the most common reason is that they're simply not available at the county level. So we don't collect original data ourselves. We use data that others have collected. We use measures that are valid and reliable and that have been tested and used by others. We try to make the ranks applicable to as many counties as possible, so we don't rank on measures where data is not available for a large number of counties. We use the most current data available prior to our release. I'm sure that some of you share our frustration with the time that it takes for some data to become available, but this is unfortunately out of our control. Each measure must be rankable, and by that I mean there must be a clear best and worst values. So based on these criteria, we change our measures of key health factors if we find measures that reflect a better data source or a better way of calculating that measure, or more importantly, if we think they're really going to help us in our communication to communities about all the different factors that impact health. If you're interested in a more in-depth look at our measure criteria, Kate will chat out a link to our documentation on this topic. So before we look at this year's measures, I'm just going to quickly show you the model, again, that they arise from. So again, there's health outcomes that are measured and health factors. The health outcomes are length of life and quality of life, and the health factors include health behaviors, clinical care, social and economic factors, and the physical environment. Now we're just going to quickly review the measures that are included in the 2017 rankings. I'll note up front, we've not added any new ranked measures for 2017. So that's the measures that we use to calculate ranks for health outcomes and health factors. But there are some important methods changes that I'll review. So first, let's take a look at health outcomes. They're divided into two focus areas, the length of life and quality of life. We weight these two areas equally since we believe length and quality of life are equally important. For length of life, we measure premature death, and to be more precise, years of potential life lost. This measure is central to our work because it carries the entire weight for length of life. It's based on deaths prior to age 75, with the belief that deaths under the age of 75 are premature and many of them could be prevented. We also look at 4 measures of quality of life. Low birth weight, which we give a weight of 20%, and this comes to us from data collected by the National Center for Health Statistics from birth certificate data. And then there are 3 other measures we use to look at quality of life that all come from the Behavioral Risk Factor Surveillance System, which I'm going to call the BRFIS for the remainder of this survey. It gets to be a bit of a tongue tie if I try and say that too many times. So these are 3 questions that are asked of individuals regarding how they feel about their health status. Oh, I'm sorry, I moved that forward. I meant to move it down. So the questions they answer are whether or not they are in poor or fair health, how many days in the past 30 they felt physically unhealthy, and how many days they felt mentally unhealthy. We include both of these to stress the importance of quality of life and the importance of both physical and mental health. The BRFIS now provides us with single-year county-level estimates for all counties across the U.S. Now we'll move on to the health behaviors section of our model. Here we include measures in 4 focus areas: tobacco use, diet and exercise, alcohol use, and sexual activity. We measure tobacco use through 1 measure in the BRFIS, adult smoking. We use 4 measures to understand diet and exercise in communities. 2 come from the Diabetes Interactive Atlas, adult obesity and physical inactivity. The 2 other measures of diet and exercise are created and constructed by us. The Food Environment Index ranges from 0, that's the worst value, to 10, the best, and equally weights 2 indicators of the food environment: limited access to healthy foods and food insecurity. Access to exercise opportunities measures the percentage of the population with adequate access to locations for physical activity. This measure is calculated by mapping parks and recreational facilities, then calculating the distances from them to where people live. Alcohol use in counties is captured by measuring excessive drinking from the BRFIS and alcohol-impaired driving deaths from the Fatality Analysis Reporting System. We measure sexual activity in counties using the rates of sexually transmitted infections and teen births. Oh, I lost my mouse. Okay, so I'm going to take a Little tangent here. As I've outlined the measures of quality of life and health behaviors, you've heard me mention the BRFIS as an important source of data. Perhaps some of you have heard in recent weeks of the release of a new data resource called 500 Cities. The 500 Cities project provides city and census tract level small area estimates for chronic disease risk factors, health outcomes, and clinical preventive service use for the largest 500 cities in the United States. Many of the same measures included in the rankings are also included in the 500 cities, and both use the same underlying model for their estimates. Be sure to take a look at their website if you have a chance. Now back to the rankings measures. So our measures in clinical care remain unchanged with the exception of a name change from diabetic monitoring to diabetes monitoring. There's been no change in the underlying data we use. This just reflects more normal ways of referring to this. So we measure access to care as the percent uninsured and combine it with population to provider ratios for primary care physicians, dentists, and mental health providers. Access to care is obviously very important, but so is quality of care. Here, we are able to provide county-level estimates for 3 different areas, courtesy of the Dartmouth Institute. Hospital stays that could be prevented with better quality outpatient care, diabetes monitoring, and mammography screening. Now we're moving on to the social and economic factors. If you recall from our model, this is the section of our model that has the highest weight overall. We assigned a weight of 40% to our measures of social and economic factors, and we divide that into 5 focus areas: education, employment, income, family and social support, and community safety. There were no measure changes in this section. We measure education using high school graduation rates and the percent of adults aged 25 to 44 years with some post-secondary education. We use the percent of the population age 16 and older who are unemployed but seeking work as our measure of employment in counties. Income is measured using the percent of children in poverty and the income inequality ratio. Family and social support is measured using the rate of children in single-parent households and the density of social associations in counties. We have 2 measures of community safety, the rate of violent crime and the rate of injury deaths. And finally, for our final health factor area, we have the physical environment, where we continue to measure air and water quality as well as housing quality and transit patterns. The only change in any of these measures is our source for our air pollution particulate matter measure. In order to provide the most updated data available, we've switched to a new data source. Using the Environmental Public Health Tracking Network, we can provide you with air pollution data from 2012, which is the most recent data that we could find available. We measure housing and transit in communities by reporting the rates of severe housing problems, driving alone to work, and long commutes among those who drive alone to work. So we've reached the end of our summary of the 2017 ranked measures. I thought I'd leave a little space here to see if we've had any questions that we might want to cover.
Yeah, great. We've got lots of questions coming in. So the first one I'm going to toss to Amanda is a question about, does the County Health Rankings and Roadmaps, do we provide data stratified by municipality or zip code?
So currently, the County Health Rankings and Roadmaps only includes data at the county level. We do this year, we're including some county data on race and ethnicity for some of our measures. I'll discuss a little later in the presentation. And we're including links in the Finding More Data section to national sources that include data for smaller geographic regions where available for each of our measure. The 500 Cities initiative that I mentioned before is another great way to find data at the municipal level or at the census tract level. We're going to be revisiting this throughout the webinar a little bit, so if you feel like you don't get your questions answered on this, please feel free to ask again at the end. Any more questions?
Yeah, we'll do a couple more now. We've got lots coming in, so we'll definitely continue to ask at the end, but we'll do another one here now. Do the rankings include any child measures, any measures related to health in children?
So we include a few measures that pertain to the health of children and youth. These include the ranked measures of low birth weight, teen births, children in poverty, children in single-parent households, and then some additional measures of child mortality, uninsured children, children eligible for free or reduced lunch, and a new measure that I'll talk about in a few minutes. I missed high school graduation, I just realized. But we do have some measures of child health and the health factors that affect children's health. So any more questions, or should we move on to the next section? All right, let's go on. We have a few more stopping points in the webinar, so we can go back for more questions then. So now we're going to turn our attention to additional measures. As I mentioned earlier, additional measures have a very integrated and prominent place in our website, and we've started to do this last year in recognition of the important role that they play in helping communities understand their health. So it's important to note that additional measures should not be considered secondary measures or measures that are less important than ranked measures. There are several reasons that measures are included as additional measures, and I'll outline them briefly now. Demographic measures are important for communities to understand the population who lives there. We don't, however, rank on those measures because there's no ideal level that would be ranked best. For example, there's no ideal percent rural or percent female or percent Hispanic in a community. Some additional measures are there to provide another look at a type of data. For example, we include premature age-adjusted mortality as a partner to our ranked measure of premature death. For some audiences, age-adjusted mortality is a more understandable and accessible measure. As we get access to new measures, we often include them as additional measures for a year or two to better understand their usefulness to communities before adding them to the calculation of ranks. For example, data on insufficient sleep and data on drug overdose deaths have recently become available and are added as additional measures. At some point, they may become ranked measures. In addition to that, there are some measures that are only available for some counties. We make every effort to only include measures that cover the vast majority of counties as ranked measures. An example of this is the measure we added last year of black-white residential segregation. Due to smaller populations of African American residents in many counties, we're only able to calculate this for 2/3 of all counties. You'll see that some of our new additional measures for this year also fall into that category. They have a fair number of missing counties for data. So let's look at some of our additional measures. I'm going to focus on our additional measures in the social and economic factors because that's where all of our changes are this year. So last year we included measures of median household income, our new measures of residential segregation from last year, and the rate of homicides. We also included a measure of children eligible for free lunch. This year we will be including 2 brand new measures and we'll be slightly modifying our measure of children eligible for free lunch to children eligible for free or reduced price lunch. This change is to fall more in line with what's commonly viewed as a measure of household poverty for children. But now we're going to talk a little bit more about our new exciting measures of disconnected youth and firearm fatalities. So let's look first at our measure of disconnected youth. This is a map of the percentage of disconnected youth by counties from 2008 through 2012. You can see that there are areas of low disconnection and high disconnection throughout the counties. This year we added a measure of disconnected youth defined as those ages 16 to 24 who are not in school and not working. These years represent a critical stage in an individual's journey towards independence, self-sufficiency, and civic engagement in adulthood. Disconnection can have health and economic costs not just for youth, but for their communities. Youth disconnected from opportunity, meaning the chance to advance in school, gain work experience, form relationships, and build social supports in the community, represent untapped potential to strengthen the social and economic vibrancy of our communities. The proportion of youth that are experiencing disconnection ranges from 0% to 82% among U.S. counties. The average value for U.S. counties is 18%. So our measure of disconnected youth comes to us from our partners at the Measure of America group. If this is a measure you're particularly interested in, please be sure to check out the website of Measure of America tomorrow, as they will be releasing their most recent data on disconnected youth. It should be a fascinating report and will give you a greater insight into this important measure. We should soon be chatting out a link to where you'll find that information tomorrow. Our other new measure is firearm fatalities, which measures the number of deaths due to firearms per 100,000 population. Gun violence is a leading contributor to premature death in the United States, particularly for youth and young adults. Firearm fatalities are a critical public health issue as they are largely preventable. The vast majority of firearm fatalities are the results of suicides and homicides, which highlight the importance of addressing violence and self-harm in communities. Our data come from CDC Wonder, and they are combined 5-year estimates from 2011 through 2015. The rate of firearm fatalities per 100,000 ranges from 2 up to 66 in U.S. counties. The average rate of firearm deaths is 14 deaths per 100,000. So I'd like to stop again briefly to check in and see if there's any questions on our new measures or anything else.
Yeah, so a couple more questions that we'll ask now. So one is the data for the measures that we use to calculate the ranks, is that all from the same year?
This is a great question. We actually get this question quite regularly. If you review, I'm actually going to go back through just quickly to some of the older slides where we listed our years of data, and you'll notice that there's a great variety in the years that our data come from, and none of them are from 2017. So although these will be the 2017 rankings, it's really important to pay attention to what year each actual measure comes from in order to really understand what you should be comparing to as you're looking to compare our data to others.
And Amanda, maybe a follow-up to that. Where can people find the years of the data for the specific measure on the website?
So there's a few places that you can find this information. If you go to our tools and resources, there is a document that you can find that is called Data Sources, Years and Measures, that you can download all of the measures and all of the data sources and all of the years at once. But if you're just going measure by measure, you might want to look on the measure page in the snapshot. So after you go to your county snapshot, you're able to click on any of the individual measures, and there you'll be able to see what year that data is from. There's a lot of ways. In addition to that, if you download our state reports or our Excel files, all of them come with all of the years of every measure included with them.
Okay, great. Another question coming in, are counties able to compare their strengths and weaknesses to other counties, or to basically how can they use their data and compare themselves to other counties, to the state, to the nation? What might that look like?
Sure, there's actually a few ways that I would recommend this. First is our Compare Counties feature that we'll be looking at a little bit later in the webinar. This allows you to compare to your county to any county in the nation for all the ranked or additional measures. Another way to do that is actually to look at our trend graphs, where we not only supply your county's data, but also supply the state's data and the nation's data so that you have some information about how different your values are from those values. I think in addition to that, it's probably worth just looking at your county snapshot and comparing. We, on every county snapshot, supply not only the state value for each of your measures, but also our top performers, which allows you, it's kind of a goal setting number, which it's the top 10th percentile of all counties in the nation. So this is really saying this is what some counties are achieving and where is your county in comparison to them.
Great, thank you. Let's do one more and then we'll move on, and we've got lots of questions coming in that we'll try to answer at the end, and some we may answer offline because there are lots. But we've got one that says, so why is the data source for physical inactivity listed as the CDC diabetes program instead of as BRFIS, which is the actual data source?
So both of these resources come from the same underlying data source, that is true, the BRFIS. We have been relying on the CDC Diabetes Atlas for some of our BRFIS estimates for several years now. Because we only recently were able to access the new small area estimates from the BRFIS program as a whole. We are a program who's wants to really evaluate all of our data and make sure that we don't make changes too quickly for any of our users. And we currently are able to provide them with several years of trend data via the Diabetes Interactive Atlas, but you can, they certainly are from the same underlying data source, although they have a slightly different model that underlies how those estimates are produced. Right, so now we can move on to some of the new features you're going to see in this year's website, in addition to looking at some of the features that we started just last year. So first, we're really excited actually about all these features, so I'll probably say that a few times. We've added a new feature for the premature death measure to help maybe look a little deeper into the data that underlies that measure. There will be a little eye icon near your estimate of years of potential life lost, and if you click on it, you'll be able to see the top 5 age-adjusted causes of death under age 75 from your county. This data comes directly from CDC Wonder, and it'll give you a snapshot of the factors that might be contributing to your county's premature death. We really hope that this is a useful tool for our users, and we can't wait to try it out with everyone. So in addition to that, we have a new feature that talks about why ranks change. Every year for 8 years, the County Health Rankings have been ranking the health of U.S. counties. Sometimes your county's rank changes, and sometimes it stays the same. And we get a lot of questions about how to interpret rank changes. Well, it's important to remember that the rankings are best used as a snapshot of 1 year of data, rather than a comparison with last year's ranks. We do want to provide some additional guidance to help communities understand these differences that occur from year to year. Okay, so why do ranks change? There are 4 primary reasons. Maybe your county experienced health gains or health losses. Changes in ranks can be due to actual changes in the underlying measures that comprise your county's rank. Or maybe other counties experienced health gains or health losses. A rank may also improve or worsen not due to a change in your county's measures, but rather because of changes in counties ranked above or below your county in your state. Another reason could be random variation in measure estimates. We know that there is error associated with every estimate that statistics produces, and a fluctuation in county rank may be caused by the random variation in the measures that comprise the rank. In addition, we do sometimes change our ranked measures or the methods that we use to produce them, and ranks can be influenced by the introduction of new measures or a change in the methods for current measures. So how can you tell which reason accounts for the changes in your county's rank? Well, I'll say first of all, it's difficult to ever answer this question definitively. Most of the time, all of these factors are playing some role. However, some clues that we look to when asking this question or answering it are, what have been the trends in your county's measures over time? And how big are the error margins associated with these measures? So we don't have time today to cover all the details of this feature, but be sure to look for it on your snapshot. Click on the eye that will be next to your rank to find all this information. Another new feature we're really excited about is our measure-specific guidance to help communities as they move from data to action. Don't bother trying to read the text on this slide, please. This is just an example to show you what you can expect to find on these pages. These short summaries will bring attention to aspects of measures that are most important for communities to pay attention to as they're working to improve health. On each of these pages, you'll find user-friendly descriptions of measures and how they were calculated, some notices about any changes that have happened in their measurement over the years, information about statistical adjustments, including age adjustment or regression-based statistical modeling. We provide an assessment of each measure's usefulness in tracking progress in communities. And finally, we guide communities towards other sources of data that are available to complement this measure, and sources of sub-county or demographic subgroup data, such as the 500 Cities project, which I discussed earlier in the webinar. We're really proud of the work that's gone into providing this guidance, but we realize this is our first try and there will be room for improvement. As you use these resources in your work, please feel free to contact us with any feedback. Another new feature this year that I alluded to earlier is the ability to get sub-county data for a few measures. The measures that we have data on specific racial and ethnic subgroups are children in poverty and driving alone to work this year. If you go to the data table associated with either of these two measures, you'll be able to view data by race within counties that have a large enough sample. We hope to expand this feature in coming years, but we're excited to have communities start using this for these measures. Another new, not new change. We've had trend maps for about 10 years, but you're going to notice some changes. So first, we've been able to offer trend graphs for two new measures, high school graduation and healthcare costs. Healthcare costs is the very first additional measure we're releasing trend graphs for, and you'll notice that the coloring of the trend graph marker is not the same yellow, green, or red as you have for the ranked measures. This is because, as I mentioned before with additional measures, sometimes there's not an ideal best value and worst value that we know. Healthcare costs can go up or go down, and sometimes those are improvements or worsenings. But you'll have to be the judge of that in your community. And we will be just supplying you the information about whether they are increasing or whether costs are falling. So you'll notice also, in addition to that, a new feature for all of our trend graphs. In order to be more transparent and offer more information for counties, we're including data tables with each of the trend graphs. So now you'll be able to know what is the actual number associated with each of those data points on your trend graph. I thought I might just spend a minute reviewing some features of our website that were added in recent years. So since 2012, we've offered a tool called Areas to Explore on each county snapshot. Selecting areas to explore highlighted measures where communities might want to focus their efforts. These measures had worse values when compared to state or national averages. Starting last year, you also were able to select areas of strength. Our team used a variety of techniques to identify health factor measures for your county that seem to reflect areas where your community is having the most success. We identified measures where there are meaningful positive differences between the county's values and either the state average or the national average. So here you can see what an example of an area of strength looked like for one county in Hawaii last year. As I discussed a little bit in before too, our ability to compare counties expanded last year. We added the capability for comparisons of counties across state borders. This should be particularly useful for border counties whose adjacent counties may be in different states. We've heard from many users how useful this feature is for them, so give it a try if you haven't yet. Well, that concludes the presentation portion of the webinar. I think we have time for questions from the audience. Some of you have been chatting in questions throughout the webinar, but if you've been holding on to your questions, now's the time to ask away. Okay, so let's see what we've got.
All right, so the first question is, on the slide that you showed with the disconnected youth, that new one we're highlighting, there's a lot of gray on that map. What does the gray mean?
Well, that is a really good question. I'm going to go back to this map so we all know what we're looking at. We're almost there. Here we go. Okay, so I know we mentioned one of the reasons that sometimes a measure is an additional measure is because we are not able to get data for many counties in the nation. This is true of disconnected youth. Because we are looking at a very small subset of people, just youth ages 16 to 24, and trying to estimate something that is a not utterly uncommon occurrence, but somewhat uncommon occurrence, it can be hard to have enough sample size to accurately estimate the rate of youth disconnection. So the gray counties are counties for which we have no data available at this time.
All right, thanks. Another question to maybe just reiterate, will there be more data points or more measures where we will be providing the trend information for the county?
Yes, there will be two new measures that we have never provided trend information before. That is high school graduation and healthcare costs. We are slowly adding measures as we collect enough information to well, really construct a reliable trend model. So it takes a few years usually to get to that point.
All right, thank you. Next question is, do the rankings include any rates of substance misuse?
That is a really good question. So we include two measures, well, three, maybe more, of substance misuse. So we do include some. In alcohol use, we measure it two ways. Excessive drinking is a measure of both binge drinking and chronic heavy drinking, both indicators of alcohol misuse. We also look at the percentage of all motor vehicle crash deaths that have alcohol involvement as an indicator of dangerous drinking and driving behavior in communities. We include a measure of adult smoking to measure smoking behavior. And as an additional measure, we include a measure of drug overdose deaths that for many counties, but again, it is well, fortunately, a rare enough occurrence still that for many counties we are unable to report death rates. But those are our measures that are available.
All right, thanks. I know that's a topic on the forefront of lots of counties. Okay, so a question about one of our new additional measures. If your county population is under 100,000, will you get data on firearm fatalities?
Oh, that's an interesting question. The answer is yes, in some cases you will. Right, you're asking that question because the rate is calculated per 100,000. That rate is really just a way of kind of standardizing across counties that have very, very different population sizes. Should I be closing this? Okay. So in some, like if there were 3 firearm deaths in a county that had 20,000 and 300 firearm deaths in a million, in a county that has 1 million people living in it, it can be hard to estimate what kind of risk, if is there a difference in the risk that people living in those 2 counties experience. And setting a standard for the population size, calculating a rate instead of reporting just the total of number of deaths, really helps communities compare the level of risk that their residents are facing. I hope that helps.
Yeah, I think it was helpful, and if it wasn't answering your question, let us know, and we'll see if we can take a second pass at it. So we're going to go back to the disconnected youth map, and can disconnected youth be subgrouped by race?
So unfortunately, not at the county level. We are unable to provide estimates of disconnected youth by race, but I know if you go to the Measure of America report that's coming out tomorrow, you can see some national estimates of disconnected youth by race. So.
All right, thanks. So let's go to, so we have some questions about other things that we might include in our rankings. One of them is info about distracted driving. I know that's become an issue. Do we include that? And if not, maybe why not?
Well, that is a really interesting suggestion. Unfortunately, I'm not aware of any national sources of data on distracted driving. Although I will say I wouldn't be surprised if the data source that now collects data on drunk driving might someday include that kind of data. We'll definitely keep an eye out and see if they have any plans to do so. Great question.
And so I know that you talked a little bit about our Compare Counties feature. Do we provide anything around peer counties? So counties could compare themselves to other counties that are similar size, average income, demographics, maybe urban, rural population, looking at that kind of stuff.
Well, one of the reasons that we included the ability for counties to be able to compare across state lines is to give them this ability. If they are aware of peer counties who are in states other than their own, they should very easily be able to do that. I know that there are some programs that do supply lists of counties who are like your county, and perhaps finding some of those might be a useful way for you to find some of your peer counties.
All right. Sorry, getting on and off mute here. Sometimes more challenging than it looks. So a question about, do we measure homelessness, and in particular homeless youth?
That is such a good question. I will say I have spent many hours really trying to find data on homeless youth, and especially really as we were looking at disconnected youth, this kind of came up as, you know, are they included in that measure or not? Unfortunately, homeless youth and homeless people in general are among the most disconnected in society. And we cannot currently find a source of data that's available at the county level that's reliable. There are programs within states that do collect this data, sometimes at a very local, at a municipal level, and have that data available. But unfortunately, nothing that we are able to put into counties and have available nationally. But it's a great question, and it's an important issue.
Yeah, and I would just add, I think this is where we always say the rankings are a starting point. They give you a kind of a picture of what's happening around health in your community, but certainly every community has additional challenges. And again, Amanda mentioned how we select measures, and we do have some limitations based on providing county level data across the U.S. So certainly if these are issues that are important in your community, we've got resources to help you think about how to find other data sources, how to collect data that may not be readily collected and used at a national level. So just because it's not there doesn't mean it's not important, and we would definitely say, you know, think about how you can get that information at your local level. I think we've got time for one or two more questions here before we wrap things up. So one is another about more good ideas for what we might include in the rankings. Do we include anything around screen time? I know that's a big thing with diet and exercise and youth development. Anything, heard of anything about screen time measures?
Muted the whole time? Oh, so sorry about that. I guess I was muted. Unfortunately, I am not aware of any resources nationally available that measure screen time. Data on children and their behaviors can be quite difficult to measure and for us to obtain. But I think this is another point where we really recognize that the rankings are a starting point, and perhaps it would be possible to collect this data in your community. Mm-hmm.
All right, great. And I do want to share one of our listeners shared a suggestion that those looking for information on homeless youth can maybe ask their local shelters about how many youth they have to turn away. Again, as a starting point, it may not be a perfect measure, but a great way to maybe get some information. All right, last question. Will healthcare costs be broken down by the diseases?
Mm-hmm. Unfortunately, we don't have any information on that, so we won't be able to supply that information. But I wouldn't be surprised if in your community your local healthcare systems might be able to supply you with some of that information. That is possible. So they might be a partner who you would want to work with on that.
All right, so I know that we have more questions coming in. Some of them are pretty deep and maybe not as easy to answer live on air on the webinar, and some of them are a bit specific, and we might be better to follow up with some of these directly. So thank you guys for being such an engaged audience, and I think Amanda's going to take us back to some slides for a few other resources to be on the lookout for. And again, thanks for your time and for joining us today. And slides will be available after the webinar. It's a busy time of year for us, so we appreciate your patience, and those will be available to you. And the webinar has been recorded and will be available as well if you need to listen again or share it with others.
I'm so sorry, I was muted again. Sometimes I really have trouble with that. Okay, so some upcoming webinars include how to craft a quick and persuasive message, the 2793 rule. That's next week, and I have to say I've used this myself, and it is incredibly useful. So definitely join that webinar if you haven't been introduced to the 2793 rule before. In addition to that, on April 11th, there'll be a County Health Rankings and Roadmaps 101 with an extensive tour of the new website features. So if you're interested in some of these features but you can't find them on the 29th, either contact us or please join us on the April 11th tour. Again, the County Health Rankings release is March 29th. If you're interested in finding out what's happening in your state for the release, please, on every state page, or nearly every state page, we have a contact who would be happy to share that information with you. If you can't reach the person, please feel free to click any of the Get Help buttons, and we'll be sure to connect you with someone who can help you out with that. So stay connected with us, follow us on Twitter, connect with us on Facebook, or sign up to get our e-newsletter. And thank you so much for your time and interest. We're really excited for March 29th, and we hope you are too. Thank you.